We'll move forward to our next session. To chair the session, I would like to invite Dr. Abhinav Sharma, Senior Consultant, Medical Gastroenterology, CK Birla Hospital, Jaipur. Dr. Bushra Fiza, ma'am, Professor in Biochemistry at Mahatma Gandhi Hospital, Jaipur. And Dr. Ramesh Rupai, sir, Senior Consultant, Medical Gastroenterology, Jaipur. Thank you.
Good morning. Very interesting talks going on, and the question which Dr. V.K. Kapoor Sahab presented is the most important one, that how to make an early diagnosis and how to answer that young lady that who has got a gallbladder stone, should she be operated or should not be operated. To answer this question, the preliminary thing, we'll request Dr. Pankaj Gupta to come over and give this talk on are we likely to have a image modality which can diagnose gallbladder cancer in early stage. Dr. Gupta.
So I must add that Pankaj is the lead person for GB RADS, and he initiated this and got a group of gallbladder cancer experts from within and outside the country and published.
Thank you for this kind invitation, and I'm indeed very grateful to the organizing committee for inviting me here. I've been asked to answer a very difficult question, based on what evidence we have at the moment, that whether we will have an imaging test that will be able to diagnose early GBC. When we talk about gallbladder cancer, usually we are looking at three different morphologies. That's very important to understand, because when we talk about literature, there is usually a mix of the cases which are talked of, and usually the subgroups are not analyzed separately. So this is a locally advanced gallbladder cancer, because we see a GB mass here, which is not difficult to diagnose, but at the same time, this represents a locally advanced tumor, which we are not interested in this particular talk. We have a polypoidal form of gallbladder cancer, which does give us an opportunity to diagnose a malignant polyp versus a non-malignant polyp. And then we have asymmetric mural thickening in the gallbladder, which again, we would be interested to know whether it is malignant or not. But we know that gallbladder wall thickening presents a great diagnostic challenge, because it's a very non-specific finding, and both focal as well as diffuse gallbladder wall thickening can be seen in benign as well as malignant conditions. To begin with, we actually did a systematic review to understand whether a grayscale ultrasound, what are the findings and the diagnostic accuracy of grayscale ultrasound in being able to differentiate benign from malignant gallbladder wall thickening. And in this systematic review, which comprised 70 studies, we found that echogenic foci, hypoechoic nodules, and lack of gallbladder wall disruption were features that favored benign gallbladder wall thickening. On the other hand, focal thickening in distinct liver interface were the findings that favored malignant gallbladder wall thickening. But as you can see from the figures here, the diagnostic performance is at best moderate. So the next question is, what is the role of Doppler in early diagnosis? Unfortunately, there is very limited literature on Doppler, and my personal experience is also Doppler is very subjective. In general, ultrasound we believe is subjective, but Doppler parameters are very, very difficult to optimize. And I found this study where actually around 60 patients, but all of them were masses, were recruited, and some vague figures were given, and which actually cannot be extrapolated to early diagnosis of GBC. So I believe that Doppler does not have any role in the early diagnosis of gallbladder cancer. Contrast enhanced ultrasound is being utilized in several cancers, and we see some role in gallbladder cancer as well, particularly when we see patients where there is a confusion whether we are dealing with a tumefactive sludge versus a polypoidal lesion. And also in patients with gallbladder wall thickening and polyps per se, it has a problem solving role when we are not very clear whether the lesion is benign or malignant. So this is just a review of the available studies on particularly gallbladder wall thickening, where CUS has been utilized. And the summary of these studies is that CUS would add to diagnostic performance of grayscale ultrasound in distinguishing benign from malignant gallbladder wall thickening. And the features that favor malignant gallbladder wall thickening are heterogeneous arterial phase enhancement, inner layer disruption, and early washout of the contrast. And we do have tools on, at least I am aware, on transabdominal ultrasound, which can give us a CT-like minimum intensity projection image, which can highlight these branched linear intralesional vessels that also suggest that the lesion is malignant. This is another, modality which has been very little studied for GB per se. This was a very early study that was performed that was in patients with gallbladder wall thickening only, and that showed that shear wave elastography has some role in distinguishing benign from malignant gallbladder wall thickening. But when you go into the details of this study, there are, majority of the patients have even clinical diagnosis of acute cholecystitis or chronic cholecystitis, and does not really represent the population which probably we are looking at to distinguish benign from malignant gallbladder wall thickening. This was a study done by our group, which was a prospective study, and unfortunately again this study comprises all morphologies of gallbladder cancer, including masses as well as wall thickening and polyps. But we did find that as a whole group, when we use shear wave elastography at a particular cutoff, it has a high sensitivity and specificity. But my personal experience is that again this modality is subjective. Objectivity is very, very difficult to achieve. 3 different people will do shear wave elastography, we will get maybe different values. So there is need for standardization of shear wave elastography to be utilized as a good tool for early diagnosis. This is the collaborative work which Professor V.K. Kapoor was talking about, which was done with support of all the experts. And we believe that with an objectivity to gallbladder reporting, we may be able to may not be able to diagnose early cancers, but at least we will not miss cancers if we report the gallbladder ultrasounds in a proper way. And we identified certain objective changes within the gallbladder wall that should be reported, and that will help us in making a diagnosis of different risks of gallbladder cancer. So this is one important image which shows us that the layered appearance of the gallbladder wall is seen not only on EUS, but it's very well seen on the transabdominal ultrasound as well. So we can see the inner echogenic layer separated by a hypoechoic layer, and then there is an outer echogenic layer, and within we have a stone. Then we should look for the intramural echogenic foci, which are suggestive of benign disease, as well as intramural cysts. So these are other things which we want to look at on ultrasound. And the third important thing is we want to look at the interface of the gallbladder wall with the liver. Obviously, in this case, we see a very distinct, sharp transition from the gallbladder to liver, whereas in this case, we see that there is a sort of indistinct interface with the liver. So we, clubbed all these features together and gave a risk score starting from GB 0, where we should actually declare that the gallbladder ultrasound is suboptimal or inadequate, and we should not really rely on the findings of ultrasound to label a patient as having a particular disease. And then we have progressively increasing risk scores, and we use very simple, objective findings, and gave some proposed risk. This was not based on any original study, but this was just a proposed risk that we gave for different, risks of gallbladder cancer in these forms of thickening. So this is a representative case. In this patient, we can see that there is diffuse asymmetric mural thickening. There are no intramural changes, and we see that the distinction between the gallbladder wall and the liver actually cannot be made out. So we labeled this case as a GB 4 lesion, which means that malignancy is likely. CT was done, which shows a similar findings in the gallbladder, a thick enhancing inner layer. But what we additionally see here is a periportal lymph node which could not be picked up on ultrasound, and the other findings are similar. This patient also underwent MR, where we can see that in addition to what we see on CT, the interface with the liver again is well highlighted here. Probably some disruption of the inner layer also is seen. This patient underwent surgery, and a diagnosis of gallbladder cancer was made. Now, we did some work to really see where GB RADS actually stays in clinical practice. This was a retrospective study where we analyzed reports of 205 patients in whom the findings were not reported as per GB RADS, but there were findings of the reports, the first time ultrasound report. And what we found that just based on the first time ultrasound report diagnosis, out of the malignant cases, 42 were reported as benign. There were a lot of inconclusive cases. But you can see that with the use of GB RADS, the number of misdiagnosed, malignant cases which were misdiagnosed as benign decreased. But we also see that there was increase in the misdiagnosis of benign as malignant also. But this was a retrospective study just to see is there any potential role of GB RADS in clinical practice. We also working on the intra-reader and inter-reader agreement of GB RADS. That's important. And we found that GB RADS has a high intra-reader as well as inter-reader agreement for the overall GB RADS category. And interestingly, we also did validation of GB RADS in this study, which I showed previously, comprising of 414 patients. And we found that the risk of malignancy in these groups were coming somewhat consistent with what we originally envisioned. So in GB RADS 2, the risk was 1.2% compared to 89% in GB RADS 5. And not surprisingly, many of these cases, benign cases which were diagnosed as malignant, were because of the xanthogranulomatous cholecystitis. Ultrasound, endoscopic ultrasound gives us a very high resolution imaging of the gallbladder, because we can place the transducer very close to the gallbladder. And as early as 1999, there were proposals for the classification of gallbladder lesion, based on which one could predict the TNM staging accurately. There are recent studies also that show that the gallbladder lesion morphology can give us clue to the underlying diagnosis. And maybe the addition of contrast enhanced harmonic ultrasound would further increase the diagnostic accuracy of endoscopic ultrasound. The only problem is that it has to be done in selective patients. Doing endoscopic ultrasound for the risk stratification in every patient may not be a viable solution, because it's invasive and in many patients may not actually cooperate for a good endoscopic ultrasound. Needs a high degree of expertise of the operator as well. So these are the two studies which I found specifically for gallbladder wall thickening, and as expected, loss of mural stratification and disruption of the normal GB wall and internal hypoechogenicity are the things that favor gallbladder cancer. Now, CT is something which we believe is more objective imaging and dynamic contrast and enhanced imaging to differentiate benign from malignant gallbladder wall thickening. And we see that even the non-contrast MRI can give us some clue to the presence of GBC, which can further improve with the addition of diffusion weighted imaging and dynamic contrast enhanced imaging. So we thought that like breast cancer or prostate cancer, where we have a multi-parametric approach to MRI utilizing all the potential benefits which MR gives us, could we do a similar thing for gallbladder cancer? So we did a prospective study on multi-parametric MRI comprising diffusion weighted imaging. Intravascular incoherent motion is basically an advanced technique for doing diffusion weighted imaging, diffusion tensor imaging, which we are more familiar with in the brain, and a dynamic contrast enhanced imaging. We found that multi-parametric MRI did improve the sensitivity as well as the diagnostic accuracy of the MRI to distinguish between benign and malignant thickening. But again, the moot question whether it can differentiate XTC from the GBC remain unanswered. We had 10 patients with XTC and 10 patients with GBC. Subgroup analysis did not actually yield any significant difference in the parameters between XTC versus GBC. So that question again remains unanswered. So these are some of the representative gallbladder cancer. There are very limited studies on PET-CT in patients with gallbladder wall thickening. This is study from our institution primarily to differentiate between benign and malignant gallbladder wall thickening. So these are all the imaging options that are available to us. So how about adding deep learning to the imaging modalities that we have with us? So our group has been working on the exploring deep learning options in GBC for 3 to 4 years now. And this was a prospective study that was published in Lancet Regional Health Southeast Asia, where we recruited prospectively patients, and 292 patients were used in the basically development set. And we tested our models on PGI data only, but this data was temporally independent. So as you can see, this data was not mixed with the training data, which is very important when we are analyzing these studies. And what we found was that the area under curve for the deep learning models was comparable to the expert radiologist in differentiation of benign and malignant lesions in the overall group. What was encouraging here was the fact that for gallbladder wall thickening, which is a difficult problem for us, as well as contracted GBCs, the sensitivity of deep learning was higher than that of the radiologists. But again, one has to understand that this is data from a single center only. We have not done any external data set validation of this particular study. Another work which we recently did was the differentiation of xanthogranulomatosis cystitis from GBC on ultrasound only, and we use the models that we got from the previous study as well as some other novel deep learning methods, and we found that the models, particularly the GBC net and radformers, were performing well. I have intentionally not shown the performance of a radiologist here, because what we found was that in almost 25 to 30% of the patients, a radiologist was not able to give any diagnosis, because either the GBs were contracted or there was a wall echo shadow complex precluding the radiological diagnosis in these cases. Now, what actually we envisage in clinical practice is that we have a deep learning model where we feed a video frame of the ultrasound, and it can give us a diagnosis from that video frame only, because sometimes there may be a bias choosing a particular image. So this was a recent work which we did, where we actually trained models to pick up the most representative frame from a video of ultrasound and give us the diagnosis. This was based on 90 patients with gallbladder cancer, and what we find is that the algorithm performs very well in the classification of overall video as benign or malignant. But again, I must admit that all these works are based on single center data. We need to basically have a multi-center data to validate whether deep learning can help us in future to basically deal with the conundrum of benign versus malignant gallbladder wall thickening. I'll just talk very little on gallbladder polyp. We know that we can differentiate gallbladder polyps into benign and malignant, and in each category we have further subtypes. Recently, it has been understood that gallbladder polyps are over-aggressively managed, because overall it seems that the risk of cancer is very low in these subset of patients. So it has been proposed by experts that rather than looking at neoplastic versus non-neoplastic polyp, one should try to look whether we can differentiate benign from malignant polyp, because we really want to identify malignant polyps and tackle them rather than identifying non-neoplastic versus neoplastic polyps, because even neoplastic polyps have a very low risk of cancer in them. And I would strongly recommend that this is a very recent work done by published in radiology by Society of Radiologists in Ultrasound, where they have given a very objective risk stratification based on the morphology of the polyp as well as the size of the polyp. So if we have a ball on wall type of configuration, this is a low risk polyp. If we have a polyp with a thick stalk, this is or a sessile polyp, this will be considered as a low risk. And if we have a polyp with associated gallbladder wall thickening more than 4 millimeters, this is considered as an intermediate risk. And based on this risk stratification, the society proposed that we should sort of advise the follow-up or surgical referral or a further imaging based on this particular risk stratification. And this, they basically had in mind that they want to distinguish a benign from malignant polyp, not a neoplastic from non-neoplastic polyp. And there are a couple of studies on AI also that have shown that the combination of artificial intelligence with either transabdominal ultrasound or endoscopic ultrasound can improve the accuracy of distinguishing benign from malignant polyp. So to summarize, I still believe that ultrasound remains the best imaging modality for evaluation of gallbladder lesions in the beginning. We thought that there was some potential of advanced imaging techniques, but as of now, with limited data, we don't feel that these are ready for clinical use. The use of AI seems very promising, but what is missing at the moment is a multi-center data. So we want that multiple centers should come together and contribute data so that we can develop generalizable AI model. And we have seen that actually working for cancers like pancreatic cancer, lung cancer. There are a lot of, translational AI and deep learning models that have made a lot of impact on these cancers. Thank you so much.
Thank you, Dr. Pankaj. Over to you, sir.
So, Pankaj, endoscopic ultrasound, CT, MRI, PET-CT, diffusion-weighted MRI, they are good when we are dealing with a gallbladder cancer. What we are talking about is screening of people, maybe with stones, to find this AI and deep learning. Do you think that in the near future, you can say that, okay, a technician does an ultrasound, he or she sends the images to a center where we have a AI ML thing and which does the analysis and gives the report. That only probably will be the answer as far as radiological screening is concerned.
Yeah, absolutely, sir. So regarding your first question, yeah, the ultrasound scanners are now very high-end scanners, and as we have seen in, I have shown a few images, but definitely, I'm not talking of patients who are very obese. That's a real challenge for ultrasound, and that remains even today. But for patients who are, moderately built or thin patients, ultrasound can give us a very good, discrimination of the layers of gallbladder. And that is the reason precisely that why we kept the layering of the gallbladder wall in the GB RAD score also, because we are very confident, and in fact that is something which we always teach our residents to identify. It just takes a bit of learning curve to be able to identify the stratification of gallbladder wall. But yes, the answer to your question is that the ultrasound technique is very mature today, and there are few people who are really into ultrasound. They make all diagnoses on ultrasound. They say that even CT, I don't need CT for these particular things. And personal experience is also that I use a lot of ultrasound for a lot of different problems in in abdomen general. But yes, it is a mature technique where we can actually use it for early detection of gallbladder cancer. Regarding your second question of AI, in fact, we had done a work where we thought of making a robotic arm, where a robotic, because there are restrictions, as we know, from PNDT who can do the ultrasound or not. But we thought that we will use a robotic arm to scan a video and use that video. And that's precisely why I presented the last work of video-based detection. So yes, there are, there is definitely work, particularly in endoscopic data. For example, when they're doing endoscopy and there is a video that comes out, there are definite models that have been trained on that video endoscopy frames that can, and at certain places the endoscopy, done by operators with different experience. I believe it's the same problem with endoscopy as we have with ultrasound. And they have shown that the models are very accurate to identify, regardless of the expertise of the person who is doing it. If the right area is scanned, the models can detect the lesion well.
Pankaj, excellent presentation.
First, congratulations for your presentation. I want just to make a remark that is not something only, not a technical remark about all that we are speaking about. This study is about the identification, the early identification of a suspected lesion through ultrasound and follow-up are very interesting. I think we, as already said, we shall go in this direction. But please consider psychological aspects of the patients standing in a endless follow-up of such lesions. Theory is very nice, but we have to face with the reality of those patients. I don't know what happens in India, but in Italy, we have patients with polypoid lesion. They come to us, do ultrasounds. They have maybe lesions under 1 centimeter, let's say 8, 9 millimeter. First ultrasound after 3 months Same lesion, second ultrasound after other 6 months, maybe 1 centimeter. That is operatively dependent. Also, the measure. After the third ultrasound, the patient says, "Let me have my cholecystectomy. I cannot tolerate this psychological pressure." This is a practical problem we have to face with. It's our theoretical study are very nice, but the patient asks us practically, you assure me that 100% I will never have progression with such a polypoid lesion. For this reason, I personally anticipate the indication in very young patients, and sometimes I must operate do cholecystectomy for a patient with 7 millimeter, 8 millimeter lesion, because it's a probabilistic percentage, but it's not 100%. And we have to take into account also the psychological aspect. So we go ahead in this direction, but please consider that in the reality, this is the problem. I don't know if you agree with me.
Dr. Sigura.
Thank you. Pankaj, two questions. One is this, you showed these images which are clean gallbladder with these polypoid lesions. What happens with the stones present? How well are you able to identify all these layers and things with the stones?
So a scenario is where we have a distended gallbladder and we see maybe few stones. I mean, there is no number which I can define. But still, if we move the patient, we have to spend some time with the patient, and if we move the patient, we are able to really demonstrate that these are mobile, and we can see all the, regions of the gallbladder. That is one area or one patient we are very sure that we have, adequate gallbladder assessment of the ultrasound. But as you are highlighting that there are a significant number of patients, and we recently reviewed our data, we found that there were around 12 to 13% of patients where the gallbladder assessment was suboptimal. And we usually avoid giving any definitive, scoring or even talking about a definitive diagnosis on those ultrasounds, and we suggest that it should be based on clinical. We don't want to even advise CT in all these patients, because clinically they may be, suspecting only benign disease, or it was just for, more patients' anxiety that ultrasound was done. So in those cases, we suggest that patient should be evaluated clinically, and if it is suspected that there is some chance of GBC, then one can go ahead and do other imaging tests. MR, I somehow find is very useful. There is no data to suggest that, but particularly for wall thickening, we find that MR is much more useful than doing a CT. But I understand that at most centers in India, the surgeons are more keen to see CT than MR. But I personally believe that because we have seen several patients where actually the diagnosis is adenomyomatosis, say for example, and you can never diagnose that on CT. There are several signs that have been described, like cotton wool sign. Personally, I am very shaky when I have to make a diagnosis of adenomyomatosis on CT, but MR can actually give you diagnosis, and we know that adenomyomatosis does not have any risk of cancer. It's a very specific diagnosis on MR. So I can't advocate based on literature, but that's my personal experience that MR is much more useful when we are dealing with wall thickening type of morphology.
The second thing is, I just am curious that we read a lot, and every time it's spoken about the contrast enhanced ultrasound. Why it has not come in regular practice? Is it because of technique problem, availability of contrast, and would it add in these cases in terms of improving the diagnosis?
Personally, I am not a very great proponent of CUS. Reasons are it's a very costly modality. In fact, the cost of CUS in India is around 7,000 to 8,000 rupee. And although you can give the one vial of contrast to 2 or 3 patients, but that patient, pooling is very difficult in our setup, where we can actually ask one patient to bring and use in 2, then ask them to share the, finances. So that's one aspect, that with the same amount of, same cost, you can have a contrast enhanced MRI. That is one part. Second part is there is definite degree of expertise that is required for CUS. Because once you start doing, at least I feel that you should have a learning curve of at least 20 to 30 patients to do a good contrast analysis sound. Because I just want to give a technical point here that MI, which defines how good the resolution of your ultrasound images is, that's mechanical index, is very low in contrast enhanced ultrasound, because if you keep a high mechanical index, then all the bubbles will burst. So really focusing on the right areas in gallbladder becomes very challenging when you have put a CUS mode on, and then as the contrast goes into the patient, you start seeing the area. But if you have not focused on the right area in the beginning itself, then your entire contrast is gone. And that I have also faced several times. You have to inject a second bolus of contrast. And I mean, again, the problem is that how good you see a gallbladder on grayscale ultrasound. Similarly, you would see it on CUS. So because initial, I mean, screening is with B mode ultrasound only. And in several patients, we find that there may be stones, as you highlighted, other things which are actually precluding good assessment of the gallbladder wall per se. So I feel people who do a lot of CUS or their center has some, I mean, mechanisms for funding CUS, it's okay. But in general practice, it's my personal opinion that I'm not very fond of CUS.
I'm sorry, I need to.
So can we are running out of time. Can we move to the
I have
next?
one question, ma'am. Just one.
May-
Yeah, can I?
Maybe we can have the questions after the entire session is concluded, please. So as we explore the future goals of diagnostic and early research, so may I now invite the next speaker of this session, Dr. Subhradip Karmarkar. She is additional professor of biochemistry at All India Institute of Medical Sciences, New Delhi. And he is going to take the session on evolving landscape of basic research in GB carcinoma. So over to Dr. Karmarkar.
Thank you, Chairperson, and very good morning to every one of you. My special thanks to Professor Kapoor for inviting me. I'm an odd man out in this team because we have all surgeons and physicians. So I'm going to kind of justify that why basic research is important and how it could bridge the gap in clinical sciences. So feel free to stop me if you have some queries. So when we talk about basic research, I kind of involve a lot of different avenues which are fastly evolving in this particular era: genomics, epigenomics, and proteomics. So with genomics, we can get a whole lot of idea about mutations, deletions, insertions, inversions, complex rearrangements in the genome, and so forth. And each one of these will have a different clinical outcome. So we need to clarify and identify actually what is actually happening in terms of the DNA aberrations. And then we have the epigenomes, where you see a lot of cases where there is apparently no change in the mutations, there is no change in the DNA sequence, but there is the transcriptome is altered. So it leads to an something which is not within the DNA, but epigenomes like methylations and histone modifications and so forth, where apparently there is no mutations, but still we see there's a definite effect. And then of course you have the proteomics, where you have the different kind of phosphoproteomics and other kind of post-translational modifications, which are very important for the function of this for these proteins. So how basic research may be helpful to address it? One is that it can address the disease heterogeneity, where we could have a same kind of clinical presentations or nearly similar clinical presentations, but the underlying mutational landscape is different. So we need to find out exactly what sets of mutations are actually there. So different individuals may come with a different sets of mutations. And of course, there are SNPs and GWAS studies where we could find out that a few populations are actually more prone for developing GBC as compared to others. And the response to the drug in terms of SNPs and other kind of metabolomics will be also very helpful, because the same drug may be effective for individuals but may not be that effective for other sets of cohorts. The microbiome is evolving, where we have microbiome, and microbiome, where all this fungal, bacterial, as well as the viral components are actually important, because they have been found to regulate the gut metabolic axis. And early diagnosis using the exosomes, microRNA, which the other previous speaker has talked about, is also very crucial, because these are actually something which is evolving as early biomarkers, or at least to know the severity of the disease or to know the response to the treatment. So this is a very kind of an expert audience over here. So I'm just skipping the basic and the background slides. I'm just going to actually what work I'm going to present today. So in our lab, we actually started about 5 years back on exploring the role of nuclear receptors in gallbladder cancers. Why nuclear receptors? Because really it's not been figured out too detail in GBCs. And the other reason why we are looking into nuclear receptors are, I'm just going to put up over here that many of the nuclear receptors do have a role in cancer. Like you know that breast cancer is associated with ER alpha, ER beta, prostate cancer with androgen receptors. Of course, breast cancer now has also been associated with, one of my recent PhD student worked on extensively on the role of androgen receptor in the breast cancer. Myeloid leukemias and other kind of solid tumors as well as liquid tumors has an involvement of the nuclear receptors. And also we know that nuclear receptors are also very nice targets for therapeutic interventions. So we really wanted to know that what is the nuclear receptor profile in gallbladder cancer. And just to kind of go into a little basic, like nuclear receptors are actually transcriptional factors. They go and binds to the receptors which are usually within the cytoplasm or within the nucleus, and they goes over and binds over there and then do some complex translocations, goes to the DNA and eventually binds to specific DNA response elements and do the function. So what we did is that we addressed, we found that there is two lacunae in these directions. One is that nuclear receptor signaling is largely unexplored in GBC. So at the time when we started, actually there is no systematic study which has been done on the role of nuclear receptors in GBC. And also we know that GBC has a gender bias, with females about 3 to 4 times more prone for developing GBC as compared to that of the males. So we don't know what kind of nuclear receptors could be playing a role in particular in the gender disparity. So human genome actually encodes for about 48 different nuclear receptors. So we took an approach to address all of the 48 nuclear receptors using a fantastic technique which is known as nanostring, which is very similar to RNA-seq, where you can look into transcriptome, but advantage is that in RNA-seq from the clinical samples, getting a good quality RNA is a challenge. So usually if the RNA RIN score is more than 7, we kind of recommend it for doing an RNA-seq. But majority of the clinical samples will have a RIN score of 3, 4, 5, because by the time the surgeon gives us the tissues and it comes to the research labs, a part of the RNA may be degraded. So nanostring is helpful in these scenarios, because even if the RNA is degraded and even if your RIN score is as low as 1 and 2, still you can do nanostring, because it just needs the copy number of the RNA. It has a small probe tagged with a fluorophore, and then it goes and hybridizes over there. So we customize this nanostring platform because we really don't have any new nanostring probes for the nuclear receptors. So we kind of customized it for our study. It took a lot of time, but eventually we have these probes ready. So when we looked into the nanostream of all the 48 nuclear receptors which has been encoded by the human genome and looked at what is their expression profile in gallbladder cancer, so it's kind of a high throughput screening. Then we found a bunch of them are downregulated, bunch of them are upregulated, and many of them are actually unaltered. So we just took a few of them, and in this particular session I'm going to talk about one particular nuclear receptors which we kind of gone into much deeper explorations and find out that what is its role, and that is known as NR4A1. NR4A1 is a orphan nuclear receptors, means we really don't know what is this in vivo ligand is. It does exist and it has a lot of different functions, but we really don't know what is the natural ligand for NR4A1. So when we looked into NR4A1 expression in GBC as compared to that of the controls, we found that it has been downregulated. So of course there are other nuclear receptors, we are not talking about that in this particular session, so I'm just focused on this NR4A1. So you could see over here it is actually downregulated in GBC, gallbladder cancers. And few of them are upregulated. So this is a summary table where you find it across male and females that there is a downregulation of NR4A1. We also did qPCR validations to prove that our nanostring is not spurious, and then we did find that by qPCR, which is regarded as the gold standard, that in GBC there is less of NR4A1 as compared to that of the controls, which is actually in this case the cholecystitis cases. So one of the features of the cancer is migration, and other feature is invasion. So we looked into that how this migration and invasion properties are regulated by NR4A1, because if it has been lost in gallbladder cancer, it appears to, how does it affects the two different parameters like the cell migration and invasion. So we are fortunate that we have 3 different kinds of gallbladder cell lines with us, And the first two are actually highly migratory in nature, and the last one is non-migratory. So we can actually look into the cells and then look into the NR4A1's status in them, because we have these migratory cells and non-migratory cells. So this is very nicely migrates in as little as 11 to 12 hours. It actually migrates and fills the wound. So this is an wound healing assay where you grow a lawn of cells and make a wound or a scar at the center of it, and then allow the cells to heal. So if they are migrating, they are going to move, and then they are going to fill the heal. So how fast they are going to do it? We actually did it with time-lapse video microscopy, and we could see that this is another population of the cells which are again filling the wound pretty fast in about 17 hours. But if you look into the third one, it really migrates very fast, but eventually it never fills the wound, and they kind of go and get stagnant, something like an border or LOC kind of a thing, where they don't proceed beyond that. So now we have two different cells types, one migratory cells and we have a non-migratory cells. And then we ask this question that what is the NR4A1 status in these two different cell types? So this is actually, we looked into the NR4A1 across the different nuclear receptors, and then we also do it by qPCR in the different gallbladder cell lines, and we could see that in vast majority of the cases, if you see over here in those circles, one at the extreme right, that NR4A1 over there, in these highly invasive cells, this is very less. The blue one is actually, the histogram is actually showing the non-invasive cell, which I showed just now, which really doesn't migrate, the last one in that one, in the previous slides. And those two small bars, which is very less, actually are the one where the NR4A1 is lost in those invasive cells. So now we know that the cells which migrates very less, which migrates very fast, they had different distributions of the NR4A1 with a reciprocal relationship. So the fastly migrating cell has very low amount of NR4A1, and the non-migrating cells has high amount of NR4A1. So this is something what we confirmed by PCR, and we could see that NR4A1 has been lost almost like 8 to 9-fold in the case of these invasive cells as compared to that of the non-invasive cells. So this is all compared fold change, log to fold change with compared to the non-invasive TGBC24 cells, and the NOS and 415 are highly invasive, highly motile cells, and you could see that they are almost like 8 to 6-fold down regulation of NR4A1. So we looked into, this is another name of, actually this is the other name, NCBI name of NR4A1, NUR77, so they are actually the same molecule. I just kind of toggle between these two names. So we could see that in cases versus controls in the actual patient samples, there is a decrease in the number of NR4A1. Of course, our sample number is low, but still you could see a trend that there is a loss of the NR4A1 in the highly invasive and highly motile cancer cells. So NR4A1 downregulation could be one of the factors that actually tells the cells to actually migrate. And once we put that data, so reviewers actually asked us that, okay, if NR4A1 is really that important for cell migration, prove it that it is really important by putting NR4A1 back into the cells and see that the migration status is altered. So we are fortunate that we have an fungal metabolite which is known as cytosporin B, CSNB, which induces NR4A1. So in these particular cells, NR4A1 status is very less. Now if we induce NR4A1 by cytosporin B, then we see that the motility of the cells actually improves. Or in other words, with respect to the controls, we could see that once we put in cytosporin B, which is in the green one, then the motility of the cells goes down. So this is a rescue experiment which shows that if the cancer actually loses NR4A1, which they do lose, then any way to increase the NR4A1 is going to have a better outcome for the cancer because it reduces the cell motility. We next looked into the invasive properties, because if the cells are motile, still it doesn't mean that they will be invasive. Invasion of the cells means they are going to release a lot of proteases like MMPs and cathepsins so that they can actually eat the basement membrane and can go to distant sites. So we did an invasion assay, which is a matricial invasion assay where you have a collagen membrane cells are shedded on them, and we looked into how many cells has migrated to the other part of it. The first two, G415 and NOS, are actually highly invasive cells. You could see that those cells actually migrated, and lot of cells are there actually on the other side of the membrane, whereas TGBC24, which really doesn't moves, has a low motility, is also low invasive, because we could hardly see any cell which has been passing through the membranes by, by matricial invasion assays. So once we have that, and then what we did is that with that background, we now induced the NR4A1 with the help of cytosporin B over here, and we found that now the number of invasive cells are also been reduced. So in other words, if we increase the level of NR4A1 in gallbladder cancer, then it reduces the cell motility, it also reduces the invasiveness of the cells. So NR4A1 is evolving as a wonderful novel tumor suppressor in case of gallbladder cancers. So I'm just shifting a little gear over here. So when we started back in genomics, we all know that first human genome, when it was sequenced back in 2000 in the landmark Nature and the Science paper, the whole genome sequencing cost close to about $200 million. Right now, on a NovaSeq platform, which actually gives us about 2 by 150 base pair in rates, the genome sequencing actually cost us little less than $100. Actually, we pay about 10 to 11,000 rupees in Indian currency. So this means that we can take advantage of these technological developments and can get a lot of genome sequenced, because there's a lot of heterogeneity in the genome. When you sequence, so far a lot of gallbladder cancers, we see that even though there are few mutations which are overlapping across the different tumors, but there are also very unique patient-specific mutations. And we really don't know whether those are drivers or messengers, passenger mutations, whether they are related to the disease progressions or they just kind of comes with the disease. So we just have to figure out on that particular aspect. So NGS has a lot of applications, as I was showing you in a couple of the other slides also, that it helps us to know about the cancer susceptibility genes, about the risk management in terms of whether it's the driver mutations or whether these are passenger mutations. The role of microRNAs, I think Kapoor sir was actually talking that microRNAs possibly are not leading us a very good clinical insight into it, because the people may be working on a little different aspect and we may not have suitable results, but we do have actually quite a good significant development also in the terms of microRNA, because few of the microRNAs like MEAT23, MEAT374 have been associated with breast cancer with an extremely high significance. And also we need to understand that each microRNA actually regulates hundreds of different mRNAs. So it's not just one microRNA, one mRNA. So one microRNA targets about hundreds of mRNA. So it's a very complex, RNA world is very complex. So we need to understand that we just are seeing a very superficial layer of it. So people didn't really looked into the long non-coding RNAs and other RNA world and see how they are actually been important. So we did a whole exome sequencing for GBCs. I'm just not going too much detail about in this data. We got a lot of variants, and if you could actually look into that, we just filtered them according to those variants which are in the coding regions. This is an exome sequence. So all the coding regions have been actually taken, and then we could see that there are differences, there are mutations in those coding regions. And at the same time, we also looked into the synonymous, non-synonymous, whether that mutation alters the protein or the amino acids or not, and whether they are pathogenic or non-pathogenic. So we did all of those kind of bioinfo things, and then figured out that there are about 45 to 50 different mutations, very high significant mutations or changes in the genome which are associated with GBC. We are actually in the process of validating them, and that's actually is very complicated, because many of these mutations or changes are actually in the enhancer regions pretty much far away from the gene. And we need to do some kind of a thing what is known as EQTL, where we look into the long range chromatin interactions and try to figure out and associate it with the disease. So this is, again, we did a couple of RNA-seq studies, and we found that few of the pathways related to cell cycle and cell proliferations, apoptosis are actually been altered, which shows that GBC is possibly been associated with an aberrations in this particular pathways related to cell proliferations and cell cycle. So when we did an NR4 knockdowns using an siRNA, right now we are trying with an CRISPR editing, which is knockout. So this is just a knockdown where we have just 70% of this NR4A1 removed from the cell. And when you did an RNA-seq, we again found that these are the similar pathways getting enriched what we showed in the previous slide in the actual gallbladder cancers. It shows that in the gallbladder cancer, we are getting a similar kind of an overlapping NR4A1 loss signature. So it turns out possibly that NR4A1 is a novel tumor suppressor in GBC. These are the different applications I was talking around, so I'm just skipping this slide. And the next important thing is that getting the tissue samples for GBC is a little challenge. Kapoor sir is very thankful. We are thankful to Professor Kapoor sir because he's generously kind of sharing the samples with us, and with which we are planning to do few more experiments. But at the same time, we are also working in developing disease models, preclinical models, where we can have something where we could mimic the actual how the cells grows within the body. So most of the time when we grow the cells and have a bunch of data, these are the cells which grows in a flask in a 2-dimension. But actually when the tumor grows, it grows in 3 dimensions. So the topology is different, and unless and until we follow the geometry, most of our hits are not going to be actual hits. There could be possibly 70% will be spurious. So we thought of kind of taking the cells out of the cancer and then trying to grow them as a 3-dimensional thing, something what they do actually in the body, and see then that what are the genomic aberrations taking place, because now we are mimicking more like an in vivo scenario. So we established a few of the GBC spheroids models where you take the cancer cells, then there's a process that is known as hanging drop methods, and then when you do it, we actually get some spheroids, something like that. So these spheroids are the dark colored one. I'm going to show you a few confocal of them. They actually grows in a very nice spherical 3D shapes, and we could actually prove actually that these are actually more representative of the actual tumor as compared to just cell line derived data. And we played around with a different number of cells, what number of cells are going to give us a good spheroids. So that takes a lot of time. But eventually we figured out the actual protocol and the working SOP that we can get a very good spheroids which actually represents the actual tumor. So we also played around with the matrix because tumor actually grows in a matrix. So you should not.
We request you to summarize, please.
Yes, sir. I'm just proceeding. And just I'll take 5 minutes, sir. And this is the spheroids. So this is how actually the spheroid forms. So in the core of the tumor, we know this is hypoxic, and this is exactly what you see, that when the spheroid forms, the rest of the cells are actually light colored are the viable cells, and the core actually becomes hypoxic, which is the dark colored cells, which actually represents a real tumor. That's how the tumor actually grows. We did an confocal microscopy of this one. The green colored one are the calcine, which is for the calcium staining, shows the viable cells. And over here again we could see that the core of the tumor is all the red color, which is the dead cells, and the periphery of the spheroids are actually the green cells, which is fastly proliferating cells. In other words, we can say that our model is actually replicating very closely to actually how the tumor grows. And also the next important thing is how the tumor actually disseminates and how it actually invades. So it actually grows those spheroids, and you could see over here that from the spheroids, the tumor cells are actually migrating out and showing the distant metastasis. So we could pick up all those cells which is there in the periphery and do an EMT and other kind of things and find out that they are actually leaving the core tumors. So this is something which is in real time, and you could actually monitor how the invasive process and the distant metastasis taking place. Whereas in a non-invasive cells, we see that the core actually remains the same. It doesn't actually migrate. So it's okay. And eventually, I'm actually skipping the slides. We looked into about those spheroids and did a functional characterization of them, and look into the different pathways, and then found that majority of them actually overlaps to what we see in the actual tumors. And the last topic, I'm actually going to finish my talk with this one, that the other important thing is that how we are going to use our basic models to study the drug response. So this is something called the patient-derived organoids, where we take actually the GBCs and then grow them in a particular protocol and then treat them with the different drugs. So this is a fantastic techniques to screen large number of potential drugs and the novel compounds and look into which one of them will have a potential for a particular individual. So here I'm just showing the data for the 3 organoids. We took a total of 12 samples and did an organoids. We tested for an olaparib. Olaparib is still the drug of choice as a PARP inhibitor in triple-negative breast cancer, not in GBC, but we tested in GBC with the collaborations at Yale University, and we looked into that whether olaparib could also have a therapeutic potential in gallbladder cancer. So we took olaparib with with the standard drug, and then we looked into it and we found that in combination of this one has a better outcome. Of course, there's a lot more detail about this one, which I'm actually skipping over there. But overall, what I wanted to communicate from this, that we could have also patient-derived organoids, which could be used as an screening platforms to screen large number of compounds, novel compounds and repurposing compounds, and then we could have potential therapeutic targets using this kind of models. Of course, we have a workflow for that. I'm almost done. This is a SNP array where you're looking into the associations, and we found that there are a lot of SNPs which are also been associated with GBC. So addressing the question that why someone has a more severe disease, someone has a less severe disease, and what is the reason that few individuals progresses from cholecystitis to GBC, but many of them don't. So we are trying to find out the associations. This is a Manhattan plot showing a few of the SNPs with an extremely low p-value of a high significance. And as the medicine is actually been approaching, so you are going towards a P4 kind of medicine where it is in predictive, preventive, participatory as well as personalized. And I think basic research is going to be a fundamental player in this particular P4 medicines, where you could have a lot of inputs coming from there, which is going to help clinicians and surgeons to diagnose the tumor in a better way, not to look the GBC as one entity, but rather a very heterogeneous entity with a constellation of different changes. So I'm going to express my acknowledgements, my sincere thanks to Kapoor sir and JSF for giving me this platform to present our work. And our collaborators are from Dr. Nihar Das, who is very generous from the GI surgery, and Dr. Ratnakar, the Sharda University, Dr. Anand, and the rest of the people at the AIMS who are very helpful to give us the tissues and also helpful to kind of give us the suggestions. So with this, I kind of end my talk over here. I'll be happy to take one or two questions. Thank you,
Thanks,
sir.
Dr. Subhradip. It was excellent overview of all molecular, what is happening at molecular level. But due to paucity time, we won't be able to take any questions. Maybe question will be taken later by you.
Okay, sir. Thank you.
Only thing I would say, the idea of requesting Subhradip and the next speaker is that we are doing work, we are collaborating with them. Other clinical departments also, best would be that your own institution develops it, but if there is a problem, you are most welcome to collaborate with these groups. Thank you, Subhradip. Thank you.
For next talk, I would be inviting Dr. Shubha Rani Sharma. Her talk is on biochemical evaluation of gallstones, a step towards prevention of GBC.
While Shubha is coming, let me ask, we have two options. Either we break for tea after this, or we have tea here only and continue.
So tea here only.
Okay, good.
Thank you so much, Chairperson, and I would like to thank Kapoor sir for giving me such a wonderful opportunity to present myself, my research at such a great platform. So, I have heard the different talks that was going on, and it seemed very heavy for me because. Once we are going for the different studies, I find sometimes I think that we are getting very less samples from the gallbladder cancer patients. Means I take gallbladder stones from sir and different other sources. So for us, it's like getting sample from a gallbladder patient, and but. Don't you think that what plight would be a person undergoing who is diagnosed with the gallbladder cancer? Because as far as I know, the diagnosis is at a very later stage, and we cannot address them as we cannot come up with a solution for it. So my work is like on diagnosis, not on diagnosis. My work is like analyzing the content of the constituents of the gallstones that we are getting, and what is the real cause of the gallbladder incidence of gallbladder cancer. So in this case, we have, in Jharkhand area, we had started with the study in about 2011, and we found that the gallbladder stones are, there are pigmented kind of gallbladder stones in Jharkhand area, and the ratio was about 1 to 3, and then we used a lot of techniques like ICP-OES, SEM, EDX and all, so that we could come to a conclusion that what are the constituents of these stones. And then we have shifted to other study from 2020, where we found that in Jharkhand area itself, the incidence of the gallbladder stone, which was in the previous time, it was pigmented kind, it changed to a mixed kind of gallstones. So with the time, the scenario of the gallbladder disease or the different kinds of stones changes. So let's see what we found. These are the different kinds of gallstones that we had collected, the internal and external features, morphologically as well as with the different techniques we have studied. So talking about gallstones and gallbladder cancer, till date it is found that in the most of the gallbladder cancer cases we get gallstones, but there are instances where they are diagnosed with gallbladder cancer, but there is no presence of gallstones. In that particular instance, what do we suggest, means what do we say, why they are suffering from that gallbladder cancer? So to probe into the reasons, we collected the different kinds of gallstones, and gallstones from normal gallbladder patients, as well as we collected gallstones from the patients suffering from gallbladder cancer. Then we went through with different kinds of techniques like atomic force microscopy, high resolution transmission and electron microscopy, XRD, FESEM, FTIR, NMR, etc. So these are the results. Like by AFM we came to know about the surface, the crystality or amorphous nature of the gallstones, and we found that the cholesterol gallstones are of very crystalline kind, but the surface is very smooth. And in case of mixed stones, we got the amorphous kind of nature as well as crystal nature, and in pigmented stones we got only amorphous kind of results. Then talking about this, the same HR10, we found that this also says about the crystality, and through these techniques we can differentiate between the different kinds of gallstones. Okay, like cholesterol gallstones can be diagnosed, like with these techniques you can just say that yes, this is cholesterol gallstone, this is mixed gallstone, and this is pigmented gallstone. Like morphologically we can diagnose, but sometimes there is some discrepancies. Here XRD as well as HR10, these all say about we actually prove that the crystality is present in the cholesterol gallstones. This is FESEM analysis, which says about the compactness of the cholesterol gallstones, and the surface of the cholesterol gallstones is very smooth. In contrast, like as I am saying, that it's of crystalline nature. Okay, the crystals present in the gallstones, the cholesterol gallstones are crystal in nature, and in the pigment it is amorphous kind. And this is the study of heavy metals, where we found that the presence of arsenic, copper, manganese, etc. are higher on the higher side in the gallbladder cancer stones from the gallbladder cancer patients. This is the FTIR results, which shows about the presence of the cholesterol. Okay, with the help of FTIR, we can be very sure that this is a cholesterol stone or a mixed stone. And with the differentiation of, means pertaining to size, weight and volume also is like the gallstones from the gallbladder cancer patients is on the higher side. This has, and where there are many reports about these. And this is the result of the heavy metals that we got from the two, like from the normal patients as well as from the gallbladder cancer patients. So these were our findings that, and one more thing, with the help of NMR studies, we came to know that the cholesterol that is present in the cholesterol stones is of monohydrate kind. And the other thing is that the observation what we found is the gallstones that we obtained from the gallbladder cancer patients were always of cholesterol kind, cholesterol gallstones, and none of them were from were pigmented type or a mixed kind. Okay, and so one more thing is that in the patients who did not have gallstones, the patients who were suffering from gallbladder cancer and did not have gallstones, it was found that the bile contained a higher amount of cholesterol. So from these we draw a conclusion. I draw a conclusion that it's not actually the gallstones, or it's the presence of cholesterol. The cholesterol is the main culprit which is somehow playing some part. And here if we see, this is the interplay of the heavy metals as well as cholesterol, which is leading to the progression or the induction of the tumorous cells in the gallbladder. And so these once we are coming with the results, what my aim is like, I want to prevent gallstones or prevent gallbladder cancer. Instead, means there are people who are into early detection of gallbladder cancer and all, but what I want is, if we devise some methods by which we can prevent these things, then it would be great. So for that case, one aspect is like Andrographis paniculata, which is called Kalmeg. Actually this is very instrumental in increasing the motility of the gallbladder. And this is the herb which is very frequently used in Jharkhand with the tribals of Jharkhand. And what I found that the gallbladder stones were not present, means the patients from whom we got the gallbladder stones were not of the tribal, among the tribal people. Okay, and so I did a lot of research, means a lot of studies that studies on the different kinds of papers related to Andrographis paniculata or Kalmeg. This is called green chireta also. So this actually increases the motility of the gallbladder, and the thing is that once the motility of the gallbladder is increased, the cholesterol which is being deposited in the gallbladder can be like flushed out with the surge of the bile which comes out. Okay, so there is no accumulation of, there will be less accumulation of the cholesterol, and that can lead to, that may lead to prevention of gallstones. The one more promising approach or the research which I came across was in 2017, that they have used a particular chemical called TCO-BOP to activate the CAR receptors of mice, and that led to prevention of gallstones. So I thought that I should, but this was the thing was that the TCO-BOP did not activate the CAR receptor in the human. So this research could not be translated into human beings. So I went for search for a herbal molecule which could activate the CAR receptor of the mice as well as human CAR receptor, so that we can translate them into this human beings. So here Artemisia capillaris is a herb which contains this 6,5-dimethyl esculentine, which is instrumental in activation of CAR receptor of mice as well as this human beings. So once the CAR receptor is activated, it leads to flushing out of the cholesterol or clearance of the cholesterol by TCO-BOP. When we talk about this 6,7-dimethyl esculentine, it flushes out or clears the cholesterol as well as bilirubin. So we can prevent the incidence or occurrence of cholesterol as well as pigmented type of gallstones. And so here what I say is, if the cholesterol deposition is leading to I have giving a proposal that this collection of the gallbladder cholesterol deposition is actually inducing the gallbladder stones or gallbladder cancer. So these can be these can prove to be a very important they could have an important potential to clear out the cholesterol, and that can prevent gallstones also as well as gallbladder cancer. And the thing is that, like in our Indian scenario, we use turmeric in our day-to-day life. So we can include this Artemisia capillaris in some amount every day or in our food habits, so that it can lead to activation of CAR receptor regularly, and that can lead to clearance of cholesterol. So we have concluded that the different kinds of techniques that I have used can lead to can be used for detection of different kinds of gallstones. And the thing is that once the two aspects or the two promising the two ideas that I have come up with for clearance of for motility, increasing the motility of gallbladder as well as clearance of cholesterol can be can have a potential of debarring the occurrence of gallstones as well as gallbladder cancer. This is the paper, the first one is the bioinformatics approach that we have carried out with the 6,5-dimethyl esculentine, and we found a promising result. Now we will be shifting to the animal studies. And these are the different studies that we have carried out with the analysis of the microstructural as well as heavy metals analysis in the gallstones. Because in Jharkhand we do not have incidence of gallbladder cancer. So we get, and one more thing, wherever there is a incidence of gallbladder cancer, we have found that the gallstones are only of cholesterol kind. Cholesterol gallstones are found. So there must be some must be some mechanism by which this cholesterol is inducing the proliferation or the metastasis or the tumor formation in the gallbladder. These are different studies which I have carried out, like in vitro formation of gallstones and all. And this is the book that we have written, and it will be probably in April. It will be in the market. Thank you so much.
Yeah, so actually my hunch from a long time has been that it is not gallstone which is responsible for cancer, it is a particular type of gallstone, because in the West gallstone disease is so common, but there is no gallbladder cancer. So is it the type of stone, or is it that in presence of stone other environmental factors they play a role? And that is why we started looking at stones. Even when Ajay was with us, we started looking at them. So that's almost 15 years ago. And fortunately we had an NMR center, so we did some NMR analysis, and then we got in touch with Dr. Shubha. So idea of keeping her presentation was that all of you are operating upon patients with gallbladder cancer. Stone is a very easy biomaterial to store, unlike blood or serum or urine where minus 80 degrees required. So please keep those stones. share it with her, and then we can do more such studies. That is number one. Number two, Dr. Shubha, I would request that although Usha has left, she had to take her flight. Her hypothesis is what you are saying, that it is the motility of the gallbladder. Once the gallbladder stops functioning, then the bile accumulates there and some changes occur. So please get in touch with her, send this presentation to her, and see how we can take this Kalmeg thing further.
Sir, I have talked to her yesterday.
So in continuation of what sir has been speaking, Dr. Shubha, I was
opinion, but I don't have any evidence or to support my statement that more than gallstones, it is the bile which is there that needs an evaluation. Though we have been doing an evaluation of the bile in the gallstones without malignancy, but the bile in patients with carcinoma gallbladder, I think that needs an evaluation, because gallstones, without gallstones, both the patients have malignancy, but bile may be having some common factor in both the groups.
Sir, actually we found the concentration of cholesterol in those patients is very high in the bile. So
Yes,
that is a common thing. That is leading to gallstones as well. So something which can be carcinogenic if we are able to identify something specific in the bile.
just to add to your query, sir, like I have gone through some literature, and there are some researches which also suggest that it is the defect of some defect in the conversion of cholesterol to bile acid.
That's what,
which leads to the supersaturation of bile, and that contributes to this development of stones as well as carcinoma.
So the accumulation of the gall, somehow the accumulation of the cholesterol will lead to.
So that is what exactly like Dr. Ajay is saying, that if we do some research or we analyze the bile itself, because there are certain researches which are also suggesting to assess the cholesterol to bile acid ratio. If it can be of some help, that can also be explored.
Stones, we have done a quite extensive study long back in 2004-5. I think yes, there's always more things we can evaluate into it, and we have published number of articles at that time. But I felt that they are almost all of them have some similarity between those with malignancy or without malignancy, maybe, and we don't have bile still available which we can evaluate.
And second thing, sir, also the presence of heavy metals that needs to be explored. Yes.
So Ajay, don't you feel that gallstones are reflection of the bile only? Because I have seen largest collection of gallstones in your room in SGPGI.
Yeah, I remember that. We had a collection of more than 500 gallstones at that time. We had made a full library of gallstones. Yeah, that is correct. But I think the bile, the stones may be different, but there should be a specific difference in the bile which is causing that malignancy. Because there may be a bile without a gallstone also in a patient with carcinoma gallbladder. That will be the most important bile that we need to have. Most of the time, by the time we remove it, is either spilled out, or what happens is when we remove it and the specimen is opened at the end of the procedure, there's some changes in that bile which has already happened. So it has to be taken out as soon as we remove the gallbladder, we should take out that bile.
Sir, and don't you think that talking about this, about the gallstones and all, we need to go for some kind of prevention methods? That's I am more interested in, because once a person is having gallstone, he or she has to get.
TD sir was commenting to me, I think we need to give something to prevent gallstones for next 3 generations, and then once they don't develop gallstones, and then we'll be able to establish. So it will take longer time, so it will be difficult. I think we were discussing the same thing while you were presenting.
Saurabh, you had a question for last session for the imaging.
We do see a lot of gallbladder stones, and GB rads, I was saying, we don't get reports with GB rads. So is it because it's still not adopted by a lot of radiologists, or is it still because they are ignorant of it? So we don't know that.
Thank you for the question. I believe that it is more to do with the evolution of any reporting system, because it needs validation and more studies rather. So I mean, it is better to be aware of a system, but using it is obviously the choice of a person, the degree of confidence he has in that system, and that confidence comes when we conduct more studies, prove that these systems are performing well in a different population, and we are moving towards that step. And I mean, it is important for at least our country to conduct more studies on a system which is helping our patients. And once we have more data, obviously the confidence will also increase. But I mean, I have reviewed 2-3 studies from China where they have used GB rats. So it's not that people are not aware of GB rats, but it is just that the confidence has to be more in using this system. It's basically the same thing what we see, but putting it more objectively and then, I mean, calculating a score. It doesn't take much time.
Can we conclude, sir? So I think at this note we can conclude, and all the experts, I suppose, would agree that more collaborative studies, more multi-centric studies, and including not only basic scientists or surgeons, even nutritionists and genetic people, all have to come together to come with some more research on these aspects. And definitely, as Dr. Shubha said, that prevention is the key. So thank you all. With this, we conclude this session. Thank you.